scrupulosity in Mormon context. Thank you for coming. We're glad to have you. The audio from this session will be available for purchase at sunstone.org starting August 19th. If you have any questions during the presentation, feel free to put them into the Luba app. We'll be checking it, and there will also be an opportunity for you to come up and ask questions. At Sunstone, our motto is more than one way to Mormon. We want to foster an environment that allows many ways for people to express their faith. We invite you to help us build a community where all paths are given space to be better understood. Please support us in our mission by making a donation or subscribing at sunstone.org. About this presentation, it's hosted by the wonderful Mormon Mental Health Association, UNMU. Scrupulosity is a form of obsessive compulsive disorder focused on religious, spiritual, or moral themes for individuals associated with the Church of Jesus Christ of Latter-day Saints. Common symptoms of scrupulosity involve obsessive feelings on unworthiness, excessive urges to confess to ecclesiastical leaders or repent, overwhelming feelings that they don't have enough faith, and high levels of anxiety associated with scripture study, prayer, and temple worship. Although some individuals leave the church to try to escape their problems, scrupulosity is a problem of anxiety, not of faith. As such, it is critical that affected individuals receive appropriate evidence-based treatment for obsessive compulsive disorder, primarily exposure and response prevention known as ERP, so that they can deal with these underlying anxiety problems. This treatment approach supports clients in making a values versus an anxiety-based decision about whether or not to remain in the church. It is especially important to treat this population with exposure because many other treatments, including all forms of talk therapy that are widely used to support people navigating social and emotional dimensions of faith transitions, can make OCD worse by creating unhelpful opportunities for reassurance seeking behavior that fuels the OCD cycle. It says, I will provide, but I will not provide. Claire Breedlove will provide. An overview of the diagnostic criteria for scrupulosity, including assessments that might be helpful for clinicians, and common symptoms of scrupulosity that I see in the Latter-day Saint clients with whom I work. I will also explain the fundamentals of ERP and give examples of common exposures used with LCSW clients. Finally, I will give clinicians resources and referrals they can use when working with clients with symptoms of scrupulosity. Very excited to hear about this. Can't wait. Thank you.
Thank you, everyone. I feel like it's like survivor session with anxiety disorders here tonight. Okay, so let's jump into it. Scrupulosity, what is it? It's a super weird word. It's basically, you can also call it religious OCD. So obsessive compulsive disorder is kind of exactly like it sounds. It consists of obsessions, which are intrusive, repeated, and most importantly, unwanted thoughts, images, sensations, or urges. So this is critical. Like, you can have somebody who's obsessed with something, but if the obsession isn't ego dystonic, if it isn't upsetting to them, it's not OCD. So then the second component is, you have the presence of the obsessions. So then you also have compulsions, which are physical or mental rituals that are used to manage the anxiety. So if you, in the Latter-day Saint context, have someone who has a lot of anxiety that they're not worthy, a compulsion might be, excessive scripture study, 3 hours a day, something like that. Scrupulosity is a really old illness. It dates back to medieval times, and there are all kinds of like crazy examples of that. Martin Luther, another early example of someone with scrupulosity. So in Latter-day Saint populations, of course, scrupulosity you can find scrupulosity in all religious people, but it presents slightly differently not slightly differently, sometimes it can be really differently, according to the religious tradition. So in Latter-day Saint communities, there are several big themes that I see in almost everyone that I work with. Fear of being unworthy or not having enough faith, fear of having committed unpardonable sins, a really excessive emphasis on purity, worthiness, perfection in religious observance, fears about not being with one's family forever, not going to the celestial kingdom, fears of like having angered God, like feeling like Heavenly Father doesn't care about them anymore. And then also a need to acquire certainty about religious beliefs. So this is kind of interesting because, there's a lot of uncertainty in life, right? And so for most of us, we're able to manage this uncertainty. So like when I, drove to this conference this morning, there was a possibility that like I could get into a horrible car accident and not make it. But I don't have an anxiety disorder. I was able to like deal with that possibility and get in my car and drive here. So similarly, like religious people, like it's about faith, right? So there's an inherent element of uncertainty, but for people with scrupulosity, that is unmanageable and overwhelming. So then there's also a set of compulsions that are fairly common in Latter-day Saints. Excessive need to confess to ecclesiastical leaders. So in my practice, I will occasionally, like I make it clear to people, I'm not your Relief Society president, I'm not your bishop. This is evidence-based treatment for obsessive compulsive disorder. But I do on a couple of things will provide some like doctrinal clarification. And this is one of those points that if you look in the handbook, the list of things that you need to go to your bishop about is actually quite small. And I have a lot of clients who, feel like they need to go to their bishop about everything. And this is part of how the OCD cycle, presents for people. So, you have somebody who, maybe they got into a fight with their spouse and they feel bad about it. So instead of being able to just, apologize, deal with whatever feelings came up with that and move on, someone with scrupulosity will think that they've, committed some really terrible, grave sin and that they need to go to their bishop and that they need to talk about it. And they want their bishop to tell them, it's okay, like you're a good person, like you're going to be all right. And the problem with that is that it sets them up for a cycle of needing reassurance. So they go to the bishop's like, yeah, you're okay, like it's fine, don't, you're good. And then they leave and they feel better for a little while, but then maybe the next day they're like, oh wait, but I forgot to tell the bishop this one thing that I said. And the anxiety comes back. So it sets you up for this cycle. And then other things, excessive and repeated prayer. Sometimes I'll see people who are praying like 20 times an hour, like a lot. Scanning for levels of faithfulness. So constantly needing to ask themselves or ask, loved ones, like, are you sure the church is true? Like, am I doing the right thing? Am I on the covenant path? Mental efforts to neutralize, erase, or replace bad thoughts. So everyone has intrusive thoughts. It's just part of having a brain. Everybody has weird thoughts, disturbing thoughts, like inappropriate sexual thoughts, like the whole gamut. But for most of us who don't have OCD, just kind of in one ear, out the other, like not even something we notice or pay much attention to. But for people with OCD, certain thoughts will become very sticky, very hard for them to deal with. And they over-identify with those thoughts. So they believe that, just because I was in the temple and I had an inappropriate, what they consider an inappropriate thought about, President Nelson, that means I'm a terrible person. That means I'm not worthy to be in the temple. And, I've got to do something about it. So one of the big things that we do in OCD treatment is to try and just normalize the intrusive thoughts. Like, you're not your intrusive thoughts. It doesn't mean anything about like who you are as a person, your character. It just means that you have like a functioning human brain, and then try to help them build up their ability to like tolerate those thoughts without, feeling that they need to take action or do something like that. Sometimes people have rituals involving, common things that we're taught to do as Latter-day Saints. Prayer, scripture study, temple attendance are really common things that are involved in that. And then I think kind of later, further in the progression of the illness, we start to see people avoiding parts of their religious observance that they used to enjoy, but now find triggering. And it's important to note that it's not like they you know, don't want to go to the temple because they watched like an episode of Mormon Stories and found out that it's like influenced by Masonic rituals. Like it's not a substantive concern with whatever they're avoiding. It's an anxiety-based concern. So, what causes scrupulosity? People ask me all the time, like, is it religious trauma? Like what's going on here? And it's none of that. We know that obsessive compulsive disorder involves problems with the neurotransmitter serotonin in the brain. We also know that OCD runs in families. There are studies going on right now to identify specific genes that are associated with OCD. And I mean, I know anecdotally from my practice that it absolutely runs in families. There is definitely a role of environmental factors in the development of OCD, but it's not clearly understood. And it's definitely not like a one-to-one, like you go on your mission and then you develop scrupulosity. Like that it's more complicated than that. And I think people who have OCD, people who have scrupulosity, they really want like a straightforward explanation, of course, for why they're having these symptoms. And it's just, in almost every case, it's far messier than that, that it's just a perfect storm of genetics, environment, being in the right age. So there are two primary periods of onset for OCD. There's a relatively small group of people who will experience the onset of symptoms in childhood, usually around 8, 10, 12. But most commonly, people will begin to experience symptoms in their late teens and early 20s. So, you know, same as many other major psychiatric illnesses. And this is particularly tricky for Latter-day Saints because this is the time when, of course, a lot of people are choosing to serve a mission. OCD is a relatively common illness, about 1 in 100 adults or 1 in 200 kids and teens. The thing about obsessive compulsive disorder, so there are tons of different like OCD themes, but it tends to kind of latch on to what is most important to people. So for people who are more religious, they're more likely to have scrupulosity. People who aren't religious don't present in the same way. So this is like the #1 question that I get asked. Is scrupulosity more common in Latter-day Saints than people of other faiths? It's not. Many studies have shown that Latter-day Saints have basically the same incidence of scrupulosity as people of other faiths. I actually think that there are some, when I talk to my colleagues who work with people of other faiths, I see some clear advantages actually for working with this population. You know, when you look at like Protestant evangelicals or like these really large faith groups in the United States, we're comparatively small, we're a very centralized faith. And, you know, although of course I appreciate that there's, you know, a spectrum of religious practice, there's much more homogeneity than when I, you know, talk with folks who are working with, you know, Jews or Catholics, whatever. Another thing that kind of surprised me as I began talking with people who work with folks of other faiths is that, you know, I think, so part of the treatment of scrupulosity involves figuring out like, what is this person doing that's like way outside the norm of like what's considered like normal religious behavior in the community. So like in our context, you know, if you talk to like the average American Catholic and ask them like, oh yeah, you're going to start wearing religious underwear, they would think that that's crazy. But of course, in the Latter-day Saint context, that's normal. So, you know, in a lot of other faiths, clinicians are having to spend a lot of time in treatment, like getting opinions from religious leaders, from like rabbis, pastors, things like that, because the clients need to be told that like, no, like this is like what you're doing is too much. Like you don't need to do this much to be a you know, good member of the faith. But what I've found in my own practice, and it's true of the other Latter-day Saint scrupulosity therapists I know, that our clients, if they know that we are active, that we have a temple recommend, it's usually enough, that they're, you know, willing to like take our opinion at face value. think Latter-day Saints also, the clients I work with at least, have very high levels of family and community support. And I work with a lot of adolescents and young adults, and the level of support my clients get from their families is usually pretty above and beyond, and I think is a big factor in why they do so well in treatment. So one of the reasons that I know that scrupulosity is obsessive compulsive disorder and not some kind of like faith-related problem is because almost everyone I work with presents with other OCD themes. So the two most common, it's probably not going to be a surprise to anyone in this room, relationship OCD, so an anxiety involving your relationship with a significant other. So like, should I marry this person? Have I married the right person? Like, is this, are we going to make it to the celestial kingdom? Like, those are really common concerns. And also just a lot of perfectionism, which I think isn't surprising to anyone who has spent time with Latter-day Saints. So the treatment for scrupulosity, the treatment for obsessive compulsive disorder is really clear. It usually consists of two things: a high dose of an SSRI antidepressant, so things like Prozac, Zoloft, Lexapro, and it needs to be at a pretty high dose to be effective for most people. It's a higher dose than someone would typically be prescribed for major depressive disorder or generalized anxiety disorder. So like 60 to 80 milligrams of Prozac or 200 to 300 milligrams of Zoloft for anyone who's familiar with those medications. And then we combine the medication with a therapy called exposure and response prevention. So exposure is just what it sounds like. So we're going to slowly expose someone to the thoughts that are triggering them in a structured way. And in the process of confronting their fears, they learn to manage their anxiety. So I'll give you an example of how exposure works. So something that's easier to understand than scrupulosity, and then relate it over. So if somebody comes to me and they're like, hey, Claire, I am like terrified of snakes and I need to work with them from, my job as a zookeeper or whatever. I'd be like, okay, cool. And we start out, we show you a picture of a snake. And because you have a lot of anxiety about snakes, your anxiety would spike up, but then I have you sit there and wait until you get back down to baseline. So you've had the experience once of seeing the trigger, feeling anxious, and then, being okay in the end. So then I immediately show you the picture of the snake again. And this time, because you've just had that initial experience, you're anxious, but you're probably a little bit less anxious than you were the first time. And so we continue on like that until you become habituated to the picture of the snake, and you're okay with it. It's no longer causing you an unmanageable amount of anxiety. So then we progress up to something that's like slightly more triggering. And I show you like YouTube videos of snakes over and over again, like that. And then next you're like, go into the zoo and looking at snakes through the glass or whatever. And then finally you're at the pet store, like petting the snakes. So we use that same principle in different ways, with different methods, to expose people to frequently the ideas that they find triggering in scrupulosity. And then response prevention is the second component of that. So response prevention allows us to help people like stop doing the compulsive behaviors. So if somebody comes to me and they're praying compulsively 20 times an hour, we'll start back by asking them, when they feel the urge to pray, to delay for 3 minutes. And then we progressively are going, we extend the time until they're praying much less in the end. So people have a lot of hesitation, like a lot of anxiety about exposure therapy, because it involves confronting repeatedly the things that you're most afraid of. So it's hard, but it's worth it because it's very effective. So some things that I take into account when I'm setting up an exposure hierarchy for someone, intensity of the exposures. So like, you don't want to start out by exposing somebody to something that's going to be like a 10 of a 10 for them. It's too much. Like, it'll just be a terrible experience that they have to like white knuckle their way through. They won't learn anything from it. So the sweet spot for exposures is typically around like a 3 or a 4 on a scale of 1 to 10. And I want to be really certain, especially in the beginning, that I'm setting people up with exposures that I really believe they're going to be successful at, because I want them to have good experiences, especially in the beginning of treatment, because then that gives them confidence to like continue on and to do harder exposures. I talked a little bit earlier about the problem of like managing uncertainty in OCD. And so, you know, when somebody is doing an exposure and, you know, like I have people do exposures in the temple all the time. And instead of telling them, instead of reassuring them and telling them like, no, it's okay, you're worthy to be in the temple, I instead want to, I don't want to do that, because then that just sets them up for the OCD cycle that I spoke about earlier. So I want to lean into the uncertainty instead. So it's like, well, you know, maybe you are worthy to be in the temple, maybe you're not. Like, we're just going to have to wait and see. Like, you're going to, you know, just have to give it a try today and see what happens. And so that is, it feels very counterintuitive. But, you know, once clients kind of get the hang of it, once their loved ones get the hang of it, then they're able to make a lot of progress. Frequency and duration of exposures. So ERP is like not for the faint of heart. In order to be effective, you have to do it a lot. So the typical guidelines we give clients are like an hour a day in the initial phases of treatment, because you have to repeatedly expose the brain to the trigger to change the, you know, the person's perception of what's going on. That being said, OCD is not, or ERP is not like some super long-term treatment typically. So, you know, most people are in my practice for like 3 to 6 months. And the idea is that we teach them the treatment and then, you know, get them into a good place. And then they're able to like go off into the world. And when they notice OCD symptoms starting to come up, they know how to do the exposures and are able to do the therapy themselves. So like just before this presentation, I got an email from a client who I worked with for about 6 months. And then he actually decided not to serve a mission and, you know, went to BYU instead. And he actually like sent me kind of like an update of like all of his exposures that he's doing at college, which was very sweet. But like, that's what we want. That's what we want people to be doing, to like teach them the skills, and then they're able to manage the illness themselves. So there are 2 major types of exposures. The first and the kind of easiest to understand are in vivo exposures. So like what I talked about with the snake. So in a Latter-day Saint context, I'll have people, you know, go into church meetings if they have anxiety about that. You know, we start off small, like you go in, you stay for the sacrament, and then you leave, you know, things like that. Listening to triggering scriptures or conference talks. I'll often use temple recommend questions as exposures for people who have obsessive thoughts about worthiness. I should have told John DeLynn this yesterday, but I use Mormon stories as an exposure like all the time. Because people are really worried that like if they, you know, they think it's like contagious, that if they watch anything that they're gonna like lose their faith, fall away. And so I had one woman recently who I told her to start watching like 20 minutes a day or something. And she sent me a text message a few days later and was like, yeah, Claire, it's like, it's going okay, but you didn't tell me that these episodes were like 6 hours long. So. And then a lot of people will have concerns that they're like normal, like noticing, you know, someone who they're attracted to, that's like somehow inappropriate sexual behavior. So I didn't come up with this, but I stole it from another OCD therapist. It's an exercise called Hot or Not, where we'll just like have people go out and notice, like, look at 10 people and like on a scale of 1 to 10, like how attractive do you think they are? And these things that are really benign, but for people with scrupulosity, they're like very worried that they're doing something really inappropriate. But the bulk of the work with my clients is typically done with imaginal exposure. So this is how we, like I can't just like send someone to outer darkness if they're worried that they're like committing unpardonable sins. So we have to like be a little bit more creative. So a lot of times we'll come up with scripts with like passages of text that are exploring like the underlying fears around clients' anxieties. And this is like kind of a difficult concept to understand. So I just have a sample imaginal exposure that is kind of based, this is somebody I worked with a while ago. But she would see her husband looking at his phone during sacrament meeting and just became so overwhelmed, like she couldn't deal with it. So a couple of things to note in this script. It emphasizes uncertainty, so that like she doesn't actually know what's happening with his phone. And then you see at the end her underlying fear behind this. So she was worried that like her husband was either like didn't care about church or was looking at like some kind of anti-Mormon stuff on his phone, and that they would end up, getting divorced and it would be all over. Interestingly, in this case, I did ask her husband eventually, like, dude, what are you looking at in church? Like your wife's having a breakdown. And it was scriptures. So a few like special things, I don't know, about working with this population. So, the statistics for OCD are terrible. Like for most people, it's like 9 to 13 years from the onset of symptoms before they, finally get treatment. And in my practice, I'm rarely the first therapist someone has been to. And people are really worried about a couple of things. The first is that they're going to be told that they need to leave the church, that's the only way to manage their anxiety. And then for people who have done like a little bit more research, or in some cases, people who have had bad treatment experiences, they're worried that they're going to be asked to do things as exposures that are in conflict with their core values. So the kind of classic example of this in scrupulosity treatment, and people used to do this, and I think it's thankfully fallen out of favor, is like having people with scrupulosity like tear pages out of religious texts, like the Bible or Book of Mormon, something like that. And so because of this, like most of my clients would not work with a non-member therapist. Like it just, they wouldn't feel safe, they don't trust it. And there's no reason that another like well-trained OCD therapist who had like read up on Mormonism like couldn't do the work that I do. But I think, for clients, it's just really, really important to them to know that like my agenda is not, anything but them finding some kind of spiritual life that is like satisfying to them and not driven by anxiety. So a case study of a typical scrupulosity client. So this young woman was a BYU student. She had just gotten her mission call, daughter of a bishop, really active in the church, loved BYU. But she had noticed in the months leading up to receiving her mission call that she was praying excessively, up to 20 times an hour. She was rereading religious texts. This is a peculiar thing that happens in OCD, that people will do either rereading or rewriting, that they are anxious that they didn't get the meaning of the text, that they aren't processing it properly. And so this can be really time consuming and troublesome. And then also just, kind of feelings of unworthiness that I see in a lot of my clients. So for treatment, we got her on like a really high dose of Zoloft and did a few months of ERP. We did the response prevention that I mentioned earlier, the like delaying prayer to curtail excessive prayer. And then we also did quite a few imaginal exposure scripts to deal with her like underlying fears about not being worthy. And she's on her mission. I get her mission emails every week. All worked out. So I think that people you know, a common misperception is that scrupulosity is a faith problem. And it's not. It's an anxiety problem that has faith-related content. And so I think it's really important to differentiate, you know, the kinds of faith-related anxiety we see in people with scrupulosity from people who are experiencing a faith crisis. So, I mean, there are like a lot of people in this room who know a lot more about faith crises than I do, but I think the big things to differentiate are that, you know, a faith crisis isn't necessarily a mental health problem, and that it's driven by values-based objections to, you know, church history, culture, doctrine, things like that. So it's really, really important to like sort out the scrupulosity people if they get kind of on the faith crisis track, because one, I mean, the goals of the clients are like really different most of the time. And also the treatment is totally different. So, I mean, I've never had somebody contact my practice and be like, hey, Claire, I want to leave the church and I need help. Like my clients really, like their faith is important to them. They want to be able to stay. Like the thing that scares them the most is leaving the church. And then the second thing that like the treatment's totally different. Like you wouldn't do exposure with somebody who's having a faith crisis usually. So here, this case study is an example of somebody who like was kind of treated as though he was having a faith crisis, and it caused a lot of problems because there was actually, it was scrupulosity. So this is a 22-year-old guy who, like when I first met him, it was really important for him to tell me about his like pioneer ancestors and his general authority grandfather. Like being a member of the church, like a faithful member of the church was like a really important part of his identity. So he went to BYU and began having a lot of scrupulosity symptoms. In the midst of all of this, though, he didn't have any substantive concerns about, you know, church policy, church history, anything like that. He eventually, like the symptoms became so overwhelming that he dropped out of school, he stopped attending church, and he went home and he like just completely fell apart. He tried to go to community college, that didn't work, was having a lot of problems with anxiety, like didn't want to leave the house, couldn't keep a job. So this went on for like a year and a half. And then one of his relatives had been a patient of mine, a client of mine. And, you know, I talked to this client's mom and said like, I don't know, like, let me give it a try. Let's see what's going on. So we got him started on an SSRI and exposures. And his exposures involved a lot of like returning to church activities. And then he did imaginal exposures that were focused around like, you know, not having enough faith, not being good enough. And he did really well in treatment. And he eventually decided to go back to BYU, and he's done well there. And he's now engaged. He's going to get married in the temple in a couple months. So I think the one thing that he said to me, actually, when he emailed me and told me that he was engaged, was that it was like he felt like the exposure treatment had allowed him to like return back to who he was. That being, you know, this like BYU student getting married in the temple, like that's who he wanted to be. And the anxiety was preventing him from doing that. Yeah. So just to conclude, kind of key takeaways. So scrupulosity, OCD, not a faith problem. And the avoidance that you sometimes see in people with scrupulosity is a function of the anxiety, not because they have some kind of substantive issue with the church. And then treatment, medication, and ERP. This is effective in about 70% of people, which is like a really high number for mental health intervention. And just finally, leaving the church, not a treatment for scrupulosity. So I'll open it up for questions.
I have an annoying question.
Oh, okay.
I love this.
Oh, wow, okay.
I'm trying
I
not
wasn't
to-
expecting that, but all right.
I'm trying not to like the moderator. With clients that I have experienced this with, I tend to see a great amount of paranoia
Yes,
and fear of judgment.
yes.
And I'll be honest, sometimes I'm not, and this is not like I'm not like you are, this is just something that I encounter once in a while. So could you address the paranoia piece? And how that, like, because I'm thinking like exposure therapy, how does that work with paranoia and that might be connected to this? I'm
Yeah.
sorry if that doesn't make sense.
No, it does. Yeah. So most people have a lot of shame about the intrusive thoughts that they're having. That they don't want to be having these thoughts about, like that, something inappropriate about the savior or something like that. They're deeply ashamed of the thoughts that they're having. And so, part of the exposure is, and part of why you have to do it the right way. You can't like throw too much at people at once because they'll freak out and shut down. So we want to start really small and show them that in really small ways, they can, overcome the shame, face the fears, like confront the thoughts, like the thoughts don't define them. And then, you build, and sometimes it can be a really slow process, but sometimes once people, have a little bit of success with exposure, they feel really hopeful and they have a lot more confidence to like move forward.
When you were talking about that you see a lot of the genetic component of OCD within family systems. That's something that kind of shows up. Do you find the same thing with OCD and OCP, or do you find that those are like kind of so obsessive compulsive personality disorder? Do you find that those don't overlap, or do you find that there is a?
I don't treat OCPD at all, but it's, I mean, my understanding that there is, yeah.
Obsessive compulsive personality disorder. I was curious. I also haven't seen a ton of it in presenting in session, but I see a lot of family members where sometimes the symptoms cause a lot of harm or distress around the family system. From what I've heard, that's a group that is very underserved. It's the OCPD. So I just excited.
Yeah, I mean, I think there aren't I don't know a lot of people who do a lot of OCPD treatment, like within the International OCD Foundation or anything like that. And I'm sure, like, I mean, OCD in general is really underserved. So I mean, I would expect that that's the case.
Hi, in your clinical work, do you ever encounter clients who are unwilling to engage in exposures or unwilling to avoid acting out their impulsive acts because they're familiar with the mini church teachings that prohibit things like that, or teachings about needing to maintain a perfectly sin-free life because they might die at any time, or teachings about avoiding sexual thoughts completely, or teachings about perfect obedience? And if so, how do you incorporate interventions with those clients? Yeah,
that's a good question. So I think it kind of shows up in two ways. That sometimes it's really hard to get buy-in with pediatric clients that, their parents recognize that there's a major problem and that they need to be in treatment, but the child doesn't want to engage. And so, that's a lot of like rapport building and things like that. And then I also, I do have some clients who it's just too hard. Like I think about one man who I worked with, he was like 75 years old and he was just paralyzed by, every time he would go into the temple, he would have these like really upsetting, intrusive thoughts. And I tried for like months to get him to do these like teeny tiny exposures, like go to the temple grounds and like sit there and try to think about, just like let your mind wander for like 5 minutes. And he wouldn't even do that. So there is a non-exposure based treatment protocol for folks who can't do or can't tolerate exposures. It's called inference-based cognitive behavioral therapy. It's a quite complicated treatment with the premise of it is like the opposite of exposure. So in exposure, we tell people that, you like everything's uncertain in life and you got to learn how to tolerate that. And inference-based cognitive behavioral therapy operates on the premise that like you need to understand, like you do have to have some certainties in life to be able to like function as a human being, but you need to understand whether the inferences that you're making about, you know, these things that you're encountering in your life are reasonable or unreasonable. So the OCD thoughts are unreasonable. And then, yeah, like clients all the time will like find some random quote from a conference talk or like scripture or whatever that's like, yes, be perfect all the time, like never like have perfect control of your thoughts, all these things. And the way that I handle that in treatment is to like kind of take a step back. And at the beginning of treatment for like almost all my clients, I have them reflect on like, okay, what do you think the nature of God is? Like, what do you think are the characteristics of Heavenly Father? What do we know? And what's happening with almost everyone is that, you know, they're taught like Heavenly Father is like kind and loving and you're a child of God and like all these good things. But in their mind, their faith is a rigid checklist and there are going to be horrible consequences if they're not doing all of these things. So, you know, when somebody is really caught up, like I've definitely had clients who are like caught up on particular scriptures or particular conference talks. And in those cases, I want them to like take a step back, be like, okay, like let's look at the bigger picture. And that's usually helpful.
This question is from Jenny Elledge in chat, and it was put in before you talked about this topic, but it still applies, I think. How does scrupulosity show up in faith transitioning clients? Does the faith transition seem to solve the scrupulosity, or can the OCD manifest in different ways now? And then I'm personally going to challenge that, hey, we do have people who are going to experience.
Yeah, no, it totally happens. And what I always tell people is like, okay, let's treat your anxiety. Let's do the exposure, get that all under control. And then I want you to be able to make a values-based decision about your church participation. So it's very unusual for me to have someone leave the church in treatment, but I have had people who, you know, are recovered and are doing well. And then, you know, all the things happen to them that happen to other people who leave the church and they do that.
So as I think about this, and I appreciate this dialogue, where I go is, what if their scrupulosity is a downstream effect of a high demand religion that's causing them to respond with scrupulosity?
Yeah.
The OCD isn't just an underpinning of their presentation generally, that perhaps doing the exposures is reinforcing the stresses, opposed to leaning into scrupulosity and an appropriate aversive response to stress, even if they don't have any faith transition, truth claim, historical or social mission intention.
Yeah.
And does this make sense? How do you differentiate between the two?
Right. So, I mean, the difference I think is that my clients, like they want to do all the things, like they want to be faithful. So and that's why the scrupulous thoughts are so upsetting to them, because they're ego dystonic. So they, you know, they want to be good members of the Church of Jesus Christ of Latter-day Saints. And so when they're having all of these thoughts that they're not worthy, that the church isn't true, it's deeply upsetting to them in a way that's different, I think, than somebody who reads the CES letter and then has a lot of like values-based substantive objections.
Thank you so much for doing this. I recently realized that my daughter, who's now 11, has very bad scrupulosity. And while researching and figuring out what was going on, because she's always had anxiety, but it's now going in the form of scrupulosity, where I've told this story a few times, but a couple months ago, I was leaving church early. I went to the sacrament with them, and the kids wanted to come home with me. My husband wanted to stay, and he just said, yeah, you guys can just go. And so when we got home, she said, I just have this feeling that something bad can happen to Daddy because we left church.
Yeah.
Or she'll see an accident and she'll say, well, Daddy said as long as we keep the commandments, nothing bad will happen to us. So was that person keeping the commandments? what I'm now realizing is that it is coming from my husband, that my husband actually has scrupulosity, something that I didn't realize until I started looking into my daughter. And I started seeing with him, if anything bad happens, he thinks that God is punishing him or he needs to repent of something.
Yeah.
It's never a positive.
Yeah.
So I had a couple questions. Number one, what I'm seeing with my daughter is that it makes her feel safe, a false sense of safety where as long as she follows these things, she'll be okay. But with my husband, I see that he is more it's like an adverse thing. So for him, it's not, it is safety for him, but there's a lot of well, this is the way it needs to be, and if I don't do it, then I will be punished.
Yeah.
With my daughter, it's more, as long as I do these things, I'll be safe, but I can see that transitioning into the punishment.
Yeah.
So I guess my question is do you see two ways that scrupulosity kind of presents itself, where in one, it might be more in a punishment way? My husband's not leaving the church. He hasn't been really.
Yeah.
So his thing isn't really questions. It's more,
Yeah.
the obsession of, yeah.
So there's, it's like a more general OCD symptom that like fear of causing terrible events, like it's a question on the standard assessment and things like that. So yeah, the symptoms that you're describing are common in scrupulosity, but also it's sometimes people with other OCD themes experience those kinds of fears. And it's usually very straightforward to treat with exposure. For adults and kids, but for kids especially, like I love working with the like 8 to 12. I love working with the kids. And we do a lot of work with the parents at that age, because there are a lot of things that like you and your husband can do in your household that will kind of create a container for her anxiety and make it harder for it to like expand out. So the best curriculum for this, and what I use in my practice, it's called SPACE, Supportive Parenting for Anxious Childhood Emotions. And Ellie Leibowitz at Yale is the developer. I'm happy to talk to you about it more afterwards, but it's a great, really great.
Awesome.
Yeah, so
And, sorry, I have another question. Do you see, people that have OCD or scrupulosity, do you see that they present other personality disorders or things of that nature, like, borderline or something like that? Do you see that they might have other issues, or do they kind of just have anxiety and then, you're able to focus on that?
yeah, that's a good question. There are like definitely some common comorbidities. Personality disorder, not a common comorbidity with OCD, but definitely autism, ADHD, like super common. Yeah. But either way, I mean, it's like they're, usually if you have a creative enough therapist, we can do the exposures in a way that accommodates the comorbidities.
Hey, so, just a short brief background, I'm an LCSW student.
Awesome.
I'm super excited. I had a few persons probably a year and a half ago, but also was diagnosed with scrupulosity, which was an interesting, fun situation. But, I want to, during that, one of the things that I couldn't really do was wanted to stay up and study everything that I could. I couldn't sleep. But I mean, while that was a bad side, it also beneficial because I learned so much. And I noticed in the PowerPoint, I just said that that scrupulosity was not more common in LPS. I thought I took pictures of it like that. It's not more common in LPS.
Yeah, that's true.
From what I found in my research, I haven't seen, like, there seems to be correlation with LPS numbers and scrupulosity, but that doesn't mean it's a causation. So I'm just wanting to know where that research came from, that the LPS.
So the issue that you're pointing to is that in like highly religious populations, you see higher incidence of scrupulosity.
Yeah.
So if you were to compare like Latter-day Saints with like Orthodox Jews, like there's,
Yeah.
so that's where the numbers are similar. But if you look at like, you know, Latter-day Saints with, you know, yeah, some lower demand Unitarians, yes. Yeah, I mean, it would be really hard to be a scrupulous Unitarian. So, you know, like that's where you see the difference. But there's nothing, I think when people are asked, my impression, when people ask me that question is they want to know, like, are there specific things that we're doing that are causing this? And the answer is no. Like, the church is not causing OCD. Like, this is like something going on in your brain that has to do with a genetic predisposition, a problem with the way that you're processing serotonin. And like, sure, there are age things that are factors, there are environmental things that are factors, but you know, my impression doing this work is that, like, if my clients didn't have scrupulosity, like if they had no affiliation with the church, they'd have like contamination OCD or harm or something else. Yeah.
So my question, ask the question, but probably try to put it into some context. Is there any movement in your field to eliminate the D on the end of these terms? Because I'm not convinced that they're always disorders. I joined a group when I left Utah, and it was very helpful for me. They're very much against putting the D on the end of PTS, because they believe that the disorder is the governments that dehumanize people to go shoot another human being. So that, and I realized with attention deficit, that's who I am. And now that I recognize that, it doesn't have to be a disorder. Also, I'm a bit OC. But I believe after hearing you, there are times when it is a disorder. But is there some movement in your industry, whatever you call it, to perhaps call it a disorder when it's a disorder, not always be on the evidence, so that everyone calls it so.
Yeah.
Because I believe that puts that kind of gaslights and puts the problem on the person and maybe not on the problem itself necessarily. Because to me, like attention deficit, I've seen times when that's been an advantage to me.
Yeah.
Or even OC, there are times when I want to. It's important to keep some order and stuff. Anyway,
Yeah.
thanks.
Yeah, that's a good question. And, you know, I think with you know, I work with a lot of kids, and I am always very careful. Like, I don't want to give them a diagnosis that's potentially going to be stigmatizing, right? Especially, you know, at a young age when a lot of kids, you know, are kind of subclinical. That being said, you know, every ERP therapist out there will tell you that obsessive compulsive disorder is misunderstood. There's not enough awareness, and the millions of people out there who are suffering with this disease are not getting appropriate treatment. And which is like such a tragedy, because we know that the combination of ERP plus a high dose of an SSRI is going to be really effective for most people. So there's so much hope for people who get diagnosed and treated properly, that I think, you know, that's kind of where most of us are operating from.
One more question. I have a number of people with OCD in my case, so most of them are BYU students and major students.
Yes.
And
Yes, my favorite.
most of them do not want.
Yes.
And it's almost a condition of treatment when they come in that they do not want this. So at what point do you determine that medication is a necessity? And after that, I suppose, what kind of presentation do you use to help them buy into perhaps the fact that they do?
So, I mean, almost everyone who comes to me needs to be would benefit from medication. But what I do is I tell people, like, look, let's give it 3 months of exposure and see how it goes. And if you're able to manage your OCD with just exposure, that's awesome. But if it's not going the way that you want it to, or you're not able to tolerate the exposures, you're not able to do them, then we need to have a different conversation. So, in that, I mean, it usually like, I mean, either I'm wrong, which does happen on rare occasions, or, you know, they realize that the exposures are hard and they're going to be a lot easier if they've got some medication on board. So, and these are not like terrible medications, like, you know, they're usually well tolerated. So yeah, that's what I do.
Can I just make one closing comment? For my friend here, right? In our diagnostic criteria, one of the things that I think maybe we can do a better job of discussing with our clients is there are times where you will have the criteria your whole life, right? Whatever it is, OC, ADH, whatever, PTS, right? And there are times in our lives where we will not meet the diagnostic threshold to qualify for the diagnosis. That's how we take the D off of it. We have the criteria, but we don't reach it to a point where it makes the diagnosis. So if it takes 8 criteria to make the diagnosis and you live with 6 your whole life, we consider that you're in remission. You still got the criteria, but it's not dysonic. It's not messing up your life. It's not something that you're uncomfortable, you're functioning. Does that kind of make sense?
Yeah, now that I understand what it is,
Yes.
I think at what time it was, but I believe Dr. James.
Yeah.
It's not this so far. But I believe like folks, even calling it anything disorder before you can determine whether it is or not, it's not doing this service.
It hurts and it harms, right? If we make people think you are disordered, there is something wrong with you. You just have the criteria. Your life gave you experiences that gave you these coping mechanisms. And if these coping mechanisms mess up with how you want to live your life, then you start saying it's moving things around. But if the criteria are there and you're functional and you're good and you're awesome and you're having wonderful experiences, then this is just who you are. This is your beautiful, divine, created self and how you adapted to life's experiences. Does that make sense?
Yeah, I think years to figure that out.
Me too. Me too. Me too. Thank you. Awesome. Thank you for that clarification. That's really helpful. Thanks. Thank you so much for coming and supporting.